So welcome. This is supposedly live cases from Vancouver, but I understand there's some problem with the connection from Vancouver to Toronto to here. So we're waiting to see if that can be brought together. But for now, I think we can go ahead with some talk. So Dr. Grube is going to talk to us about cerebral protection.
Thank you very much, John. And I know you are tired of this topic because it has been talked about twice yesterday, and Horst is not here actually. So this is my disclosure. I just wanted to start with this one. There was an audience response for protection at the ACC 2016. What is the biggest concern for your patients undergoing TAVR? That's 2 years back. And you can see here suffering stroke is 70%. And is cerebral protection necessary during TAVR? At that time, 2 years ago, it was 80% that said in selected patients, yes. And then you hear many arguments against it. Stroke and TAVR is declining, high volume centers or experienced operated stroke has almost disappeared, stroke is more prevalent in high risk patients, protection is complicated to use and adds time, at risk to the procedure, there's no evidence that it actually reduces stroke like cordless filters do. There's no evidence that stroke are procedural in nature, so why not use NOACs post-procedure? The only available device doesn't cover all four arteries. Sometimes stroke appears 2 or 3 days post-procedure, and of course the cost issue. Let us talk about some facts, and it begins with defining stroke. Stroke is not the same for everyone. Stroke is different, and the definitions vary by clinician, clinical specialties, and studies. Some people say this is stroke, but they would deny that this is important. But, you know, particularly I would like to draw attention to this picture, and we've all seen this. We have ignored it during bypass surgery. We know these pictures. I have it on my computer still when we talked about bypass, when the patients are successfully operated on, but, you know, something happened in their brain afterwards. And I think we should pay attention, particularly now in view of the fact that we're going into younger age groups. Known consequences of injury are well known. I don't need to repeat that. TAVR, 30-day-old stroke with contemporary devices across the board at average is still 4.4%. Stroke is very often under-recognized and under-reported in TAVR and in surgery, particularly at the very beginning when we never had neurologists involved, and that has changed obviously during the last trials. And also stroke is a procedural issue. TAVR stroke occurs per procedure less than 72 hours. Timing, risk factors, outcomes of stroke, TIA after TAVR here from the partner data. And you can see here not only apparent stroke, but also TIA had a lower 1-year survival rate. With stroke, 47% 1 versus 82, and with TIA, 64% versus 80 without. And you can see here, if we look at the meta-analysis, TAVI stroke and mortality, with stroke, mortality with stroke is going up, as you can see here 4 times. Stroke risk, unfortunately, is also independent of experience and operator volume, as shown. Peri-procedural complications, including stroke, is not different between low and high volume hospitals, as shown here. And stroke rates are not declining with newer generation devices, as you can see here. And we know the procedural, the problem during the procedure, TAVR-related stroke, is debris. It just comes off, and there are many reasons to have embolic events because we're dealing in a not very friendly environment. We have hostile arches, we have calcified valves, and you can see here the manipulation of balloons, wires are obviously a reason for these problems. Most cerebral damage, unfortunately, in TAVR is unseen. What we do see here is major and disabling stroke, but you know, many other things that are going down here we should not ignore, at least not when we talk about lower risk or younger ages. We at least have to address the issue. So what is the current state of play in preventing it? It's optimized anticoagulation, particularly when we go for later events, and embolic protection during the procedure. Some options, basically the only one out there is now the Claret Sentinel device that is CE marked. It's 2 filters, as you can see here in the innominate and then in the left carotid. And you can see the injury. We know why it happens. And this is Van Meegem's publication. You can see here any type of debris, and 86% was found in these filters. And regardless of whether you believe in the sequelae, I think it is better to have it away from your brain than have it in the brain, because the consequences are really not foreseeable, at least not for us. The published reports on effectiveness are interesting and are increasing, actually. Leading the way with clinical evidence for embolic protection, you can see here centers in Europe, and now particularly also in the United States. In the US, it is catching up. Meta-analysis of effectiveness, change in mean new lesion volumes in the protected territories. You can see here all favors clean TAVR, Mistral C, Sentinel. Overall, all favors protection. If we look at the Sentinel study, even though it was statistically not significant, we did see a 63% reduction of stroke from 8.2 to 3 in total from day 1, day 2, and day 3. Remember, even day 2 and 3 doesn't mean this is not happening periprocedurally, because the consequences of the injury might last a little longer. And here we see the freedom from stroke, the Kaplan-Meier curves with Sentinel, without Sentinel, through 3 days post-procedure, and then through 90 days post-procedure with and without. Meta-analyses of protection devices used in TAVR, you can see here altogether 1,225 patients, 6 total studies, 2 prospective observational, Sentinel-Ulm in Germany, and then ProTavi-C. And then we have 4 randomized trials, Deflect-3, Mistral C, Clean TAVI, and Sentinel. And you can see here, there's a consistent reduction in new lesion volume. Mistral C, 52%, Clean TAVR, 41%, and Sentinel, 42% in new lesion volume in the brain. Clinical event meta-analysis of protection in randomized controlled trials. You can see here all favors, and you can see in conclusion, the totality of the data suggests that use of embolic protection during TAVR appears to be associated with a significant reduction in death or stroke. And here we look at the RESPOND post-market study, the impact of embolic protection and repositioning on stroke in patients treated with a Lotus valve. And you can see here, SEP has been used particularly in Germany in 96 patients. And you can see the strokes were adjudicated by an independent medical reviewer. You can see with and without protection, the numbers are different. You can see here's less than 74-hour disabling stroke with no repositioning and with repositioning, and then here patients without 1.8 and 2.5%. So there's at least a positive effect on that. And then Sentinel captures debris regardless of TAVR valve systems. I know there's also different opinions about that, but at least it was found. And I don't believe that anyone can for sure say our valve is not having a problem. I don't think this is adequate, but it is still done, and we have to see when we do these trials whether or not that is holding true. Shall we wait for conclusive data before we use SEP routinely? I think it is important, let's use them until the data prove otherwise. Thank you very much for your attention.
Thank you, Eberhard. So maybe ask you just to stay there, or, well, you can take the mic here if you like. Because I think we have a few extra minutes, being so the live cases aren't going. We don't have a signal yet, I don't think. No? Any comments or questions for Eberhard?
Yeah, can I answer my own problems?
You can, but then I'm going to ask you one anyway.
But I think eventually there are 2 things that drive this process. Number one, I think we need a trial where we have a proof of stroke reduction. I think that's very important, and it is not the 15,000 patient trial. It can be done. It cannot be done if the big companies, because simply there's no funding. But I think that would at least resolve one of the biggest issues. And the second issue is now that you see in the United States, at least, and Vinny talked about this yesterday, there's a drive towards protected TAVR versus unprotected TAVR. This is an issue in the US for financial reasons and for litigations and all of this. I know this is all difficult, but I think there's a trend now. It is being used a little bit more in the US than in the rest of the world. At least that's what I heard.
Yeah.
Reese.
Oh, I'm sorry. Yeah, you were there.
Me?
Yes, yes,
sure.
yes.
Okay, so thanks for this very good presentation as always. The problem I have is, the company that is promoting this device, approved in the United States, have taken a hardline approach of the price. And your conclusion to say, while awaiting the data, let's try to understand it because the risk to benefit is clearly appropriate. Don't you think it is their problem of, this is a purely financial problem now, rather than a technical or a reason to use it?
Totally agree.
Could I just ask, I think it's fair enough to ask, what is the price in the U.S. currently?
So the
It's
price,
part of the decision, I think.
yeah, the price varies, but let's call it between 1,800, 2,000 to over 3,000.
Yes.
And the margins of the procedure in the United States now, of the entire TAVR, DRG, is virtually break even, virtually.
Yes.
So to go to the administrator and say, I'm going to spend over that another additional 3,000, you know what they tell you?
Yeah.
Fala here.
And the interesting thing I understand in the U.S. is that remuneration to the healthcare system varies dramatically from state to state. Some places it's profitable for the hospitals to do TAVI, others it's a big loser,
Right.
which is important, I think.
Yeah.
You go ahead.
Yeah, no, I think now, as you know, Claret is in negotiations with CMS, and they had a positive first meeting. Obviously, CMS needs clinical benefit, and that's very hard to prove under these circumstances. But the first session was positive. I think if it gets reimbursed, then I think the situation might change, don't you think?
Absolutely.
So here's an awkward question maybe, but you showed that there was embolic debris recovered with all different valve types, fair enough. But as you know, in the Sentinel trial, one of the things that wasn't really raised very much is that the incidence of new lesions and the size of lesions was markedly lower with SAPIEN 3 than with core valve. And this hasn't been discussed very much, but can you say what you think about that? Is there anything to this or no?
I think, I take my head off of, the core valve head off right now. I think what the fact of the matter is that the study was never powered to do a difference or to see a difference in valve types. And I'm not an expert in statistics, but I can tell you there was a long discussion whether or not this should be brought forward, because there were many sub-analyses of these data. And at the end of the day, I think, personally, I believe that regardless of a self-expanding valve or a balloon expandable valve or Lotus as a mechanical, I think there is always a potential risk. Whether you have in one trial a little bit less or a little bit more, I think that's fair. And in that particular case that you mentioned, I don't think, and I've been part of that discussion before the data came out. There was a very serious discussion whether or not it should be taken out. For the time being, yes, in the core valve trial, and particularly in the core valve early, there was more stroke than in the SAPIEN. In the SAPIEN S3, the SAPIEN XT was the same. So S3, there was less.
So there's another issue, is that you said that stroke rates are not falling with newer devices, and I would have thought that as you get profile down, as crossing gets easier, as you need less pre- and post-dilatation, that there would be a fall in stroke rates, and my impression actually is that there is.
Yeah.
The stroke rates are falling in relation to devices.
Yeah, I mean, the point is, when we look at these, first of all, I think now that we have this device in clinical use, it is not as positive as initially thought. So there was, the failure rate is in the range of 10-15%. That's what I heard from the centers that are using it routinely. So it cannot be done in every patient. And I'm sure that there are better ones to come. But the problem, as you know, is at this early stage, the funding and the trial and bringing it forward, and then the question is, shall we do it or not? This is all unanswered, and I think the business models for all these devices is questionable. Senator Claret has just brought it forward. I don't know how that's going to end up.
But if I can make a comment, would you actually take the fact that there are at least 80% of the cases in which there is brain damage, according to diffusion with MRI,
Yes.
Is it enough to suggest that in the majority of the cases we should use it, considering the very low rate of stroke anyway? Well,
that's
to suggest that. I mean, this is the message we should deliver.
Yeah. Now, obviously, and I try to be really fair in this question. When the study was conceived, nobody really knew. Even the FDA was not clear as to what is the best endpoint for a trial like this, and everybody was struggling with it. I remember when the PIs were discussing it together with the FDA. It was not without the FDA. The FDA was also clueless as to what should be the endpoint. Is it a clinical endpoint? Is this an imaging endpoint? Bottom line is, I don't think it is enough to convince the community that if you have changes in the MRI, that this should be a routine use, but it should be a concern.
Generally speaking, I mean, I think still evidence-based medicine reigns. And if you do a trial with these endpoints, good, bad, or indifferent, and the trial is kind of not negative, not positive, it behooves the sponsors and the community to go to the next one, having learned from the first one.
Yeah, but I agree, but what is the endpoint? Is the MRI?
It's a combination of clinical and imaging, and that has not been done yet.
Yeah, but also we should actually standardize the MRI, because there are papers done with 1.5 Tesla, other with 3 Tesla, and we all know what is the difference, because with 3 Tesla, maybe we overestimate these damages. With 1.5, we probably underestimate. So what's the goal here? To demonstrate that there is a damage or not, we know there is. However, how to translate in clinical practice? Because of course, for some patients, like porcelain aorta, you definitely suggest to use it. But in the majority of our over 80 patients, should we actually recommend that? I don't think so, to be honest. But actually, going back to the fact that we are looking forward to younger population, this is a big issue still.
Well, thanks again, and I think John is ready to go. So John, you talk about future expanding indications for TAVR.
Okay, and I may go over a little bit in time because we're still waiting to see if we have our live cases. I just got a text that this may happen. Future expanding indications for TAVR. This is just a review of a few up-and-coming things that I think are worth discussing, my disclosures. You know, we have dramatically improving outcomes with transcatheter valve implantation. This is just for the SAPIEN series of valves because it's easier for me to get the slides together. We also have dramatic reductions, I think, in stroke. Well, we have arguably stable stroke rates, but clearly less than surgical stroke rates, I think, in current iteration trials. And here's similarly with core valve TAVI, we have improving outcomes such that I think there's just going to be more and more patients we're going to have to be doing this procedure on. We have the P2A SAPIEN 3 intermediate propensity analysis, which shows a projected 4% 30-day mortality with surgery versus 1.1% in intermediate risk patients, and similarly lower stroke rates with intermediate risk patients with TAVI than with surgery. So all this discussion about emboli with TAVI, I think perhaps is even more true with surgery where stroke rates are, according to current data, even higher, to put it in perspective. This is some data from the US TVT registry, just looking at what is the actual real-world mortality with intermediate risk patients in the United States. And it really, you can see that it reflects pretty closely on the SAPIEN 3 intermediate trial and core valve data. TVT registry intermediate risk 30-day mortality was 1.4% in the US. Stroke rate 1.7%. Major vascular complications 4.2%, and mild paravalvular leaks 1.9%. Obviously this is self-reported, so probably underreported, so probably more leaks than you would think. Now, in Canada, for instance, we're addressing this. What are the indications for TAVR? And it's interesting, we had an independent body review the importance of surgical risk in relation to selection of patients with TAVR. This was not cardiologists, not surgeons, but an independent body that reviewed all the literature as part of our formation of new guidelines within Canada. And the conclusions were that regardless of risk, TAVR mortality, stroke, and rehospitalization rates are lower than surgery, and consequently, surgical risk per se shouldn't be a major decision point in terms of whether people have TAVR. The two therapies should be independently compared based on the outcomes expected with an individual patient. So our group has to review this and decide who's going to have TAVR, and the whole nature of the procedures changed dramatically since we started, when lots of people were involved in the procedures, and now it's typically one operator and a fellow in our institutions. The procedures changed dramatically, and what we've been really trying to do is reduce the cost of the procedure, because we have a finite funding envelope, and yet we want to do TAVR not just on extreme risk patients, not just on high risk, not just on intermediate risk, but really all patients are candidates for TAVR in our mind these days, assuming there aren't particular arguments for somebody to have surgery, and we don't have the funding to do that. But one of the things we've done is get rid of general anesthetic, and I know when I was involved with proctoring Massey years ago, I strongly encouraged general anesthetic, and they've left it, and so have we as well. No urinary catheters. We've moved from the hybrid operating room for most of our cases, now be done in a routine cath lab. And our patients are mobilized very quickly. They're mobilized within 4 hours of the procedure. Here's two patients watching the evening news in a lounge on a regular ward. They're both on telemetry the evening of the procedure. And almost all of our patients go home the next morning. In fact, over 90% of the transfemoral patients are discharged with 1 night in hospital and leave the next day. One of the ways that this has been accomplished is to have very standardized protocols for everything. The nurses know exactly what's going on and when to mobilize, when to D-line, when the patient should be discharged. There's standard nursing practices, and we have standard physician orders. You just sign them. You can tick whether you want Plavix or not. That's about your only choice. You can tick on whether you want patients mobilized at 4 or 6 hours. Otherwise, it's pretty standard. And patients have good teaching that really tell them that when you come in the hospital, you're leaving the next morning because we have more patients to bring in. So the procedure's moved to a procedure where patients come in the morning, there's a groin prep, they have a warming blanket, the face is not covered up, there's no urinary catheter, no PA catheter, no general anesthetic, no esophageal echo, no cut down, and the pacemaker comes out right at the end of the procedure. And by that measure, we usually finished within 45 minutes of the OR cath lab opening up our first case. And you can pretty easily do 4 or 5 cases a day without any rush. Most of the time is spent cleaning the room, not doing the TAVR. With this, our hospital stay has fallen down to a median of 1 day, and it's been there for almost 3 years now. So along these lines, we embarked on the 3M trial, which was a trial just utilizing this kind of pathway. Most of the centers involved in the trial had used general anesthetic for all of their patients. There were 3 U.S. centers in there. There was Emory, Columbia, and, well, I guess that's it, actually, and then mostly Canadian centers. But for most of these centers, this was a new thing, to do patients awake with next day discharge. And to look at the results of the study in 411 patients, you can see outcomes are really good. This is not compared to anything, it's not randomized, but I think by historical standards they're good. The mortality at 30 days, 1.5%, stroke at 30 days, 1.5% as well. On the right is the timing of discharge, and there in the darker green you can see that 80% of all patients were discharged the morning following the procedure. And about 90% were discharged within 48 hours. Now, the patients were really, this was really an all-comers study. The exclusions were you couldn't have a CT and we didn't know the size of the annulus. You needed a TE for some reason, you needed a general anesthetic for some reason. We're unsure about access for some reason. But we didn't exclude patients with low EF. We didn't exclude patients with ISTS scores. Now, one of the concerns with putting these valves in younger patients, and I'm moving towards doing more and more low-risk patients, is durability. But we know that in vitro, anyway, these valves have every bit the durability of surgical valves do. They go through the same kind of testing. Here's a SAPIEN 3 at 600 million cycles. That's the equivalent of 12 and a half years. It's still looking pretty good, albeit it's in vitro, not in vivo. Now, here's one of our valves. This is an early bovine pericardial valve, anti-calcification treatment, a SAPIEN valve. Patient died at 7 years of non-cardiac reasons. And there you can see the valve is still looking pretty good. These valves are all going to wear out if patients live long enough, but this valve has fairly mild disease, and I think is still probably going to be good would have been good for a number of years had the patient lived long enough. But most of these patients don't live that long, but some of them do. Here's one of our patients who's actually now beyond 11 years. There's Danny DeVere. He actually went to this woman's house to do the echo in her own house. Transapical case, actually a equine valve, still doing very well at the age of 97. She was done when she was 87. And here's her valve after 10 years, and now she's out to 11, as I said. Main gradient 11, really just mild aortic insufficiency, really a very good and durable result in one of these patients that actually was able to have longevity. Here's the second patient. She was done at age 86. There she is at age 96. There's her transfemoral, again, equine valve, still functioning well at 10 and 11 years. And here you can see trivial AR. By 6 years, she's got mild AR, or sorry, in 10 years, it's a little formatting issue there, but 10 years, she's got moderate AR. But interesting, she also has severe mitral stenosis due to calcification, which is interesting. You know, that doesn't stop time. And what are we going to do when these valves fail? Well, I think it's going to be pretty easy to do valve-in-valve implantations inside the TAVI valves. Here's an example of an XT inside an XT. In fact, this patient had a SAPIEN XT 26. We now know that these valves can be expanded bigger. For instance, the SAPIEN 326 could be dilated up to 29. So you could actually put a 29 inside a SAPIEN 326 if you wish to. The valve will actually get that big. So the gradients should be excellent. And we have good data from valve-in-valve registries like this one, the PARTNER 2, but also the US core valve trial, and now the VIVA registry, and also VIVID, that clinical quality of life improves really dramatically. We have some issues with, particularly with the SAPIEN type valve and in small annuli, but still outcomes are being really very, very good. If you look at on the right there in the very end, that's the TVT registry, which is a real-world registry. And here we have a mortality of 2.9%, stroke rate 1.7%, a very low rate of coronary obstruction these days, because I think people understand this issue now. Annular rupture didn't happen, and pacemakers are very infrequent. It's really a very good therapy with the concerns remaining about some of the smaller valves. So one of the things we've learned is you have to implant high with valve-in-valve implantation. This is the old way of implanting a SAPIEN valve. There's the newer way. In fact, it should be implanted higher. Or you should use a supraannular valve like core valve, or some people are now doing the same sort of thing with Symetis valves, accurate valves. Here's a cracking. Unfortunately, this computer reformatted my picture, and there's a nice split on that Paramount valve, but it's off the screen now. I can't fix that. But here's a mitral flow valve that's been dissected away to show that the plastic rings actually cracked. I know I've only got 1 minute, but I don't think we have a live case yet, so I'm just going to keep on going. Oh, we do?
We do.
Yeah. We do. Okay, well, I'll wrap this up pretty quickly. Here's an example of cracking. This is a 23 SAPIEN valve and a Mosaic 25. Here it's been dilated with a dramatic reduction in gradient. You can't see the cracking because this is a radiolucent ring in this particular valve, but you do know that the gradients go down dramatically, so you can treat these patients very effectively. Now, this is another formatting problem that's fine on my computer, but flip this around and unfortunately hasn't been fixed. They're working on it. This is actually a Paramount 23 dilated with a 28 balloon. A 29 valve was put inside this, just to show that this is feasible, should you be so foolish as to want to try and do that. We still know that coronary obstruction is a concern. Here's the only procedural death inside the PARTNER 2 valve-in-valve registry. You can just see how that left coronary artery is just a setup for occlusion. That's exactly what happened because this patient slipped through screening somehow. And, you know, but now we know how to screen these things, usually with a simulated valve and an annulus, and measuring the valve to coronary distance is fundamental to this, I think. And there's various approaches. One is protection. And I'll just show you one of our cases. Here we have a partial coronary occlusion. There's a stent afterwards. At 1 year later, look, there's restenosis of the left main artery. And I would just take the position that if you think you're protecting left coronary arteries with a stent, you're really playing a fool's game. You may get the patient out of hospital. I know you can bail these patients out, but it's really not a very good long-term outcome. You need to follow these patients. And really, if you're at risk of left main obstruction, I think the question really should be, should you just have surgery? There's a new approach for this that's going to expand these indications, perhaps. We'll see this is the basilica procedure, and this involves sort of a lampoon-like slicing of the leaflet adjacent to the coronary artery. Here you can see the leaflet is perforated, and then the wire is snared, and then this is going to be heated up and slit back, and there you are. There's your slit valve. And now when you do a valve-in-valve implant, whether it's a core valve or SAPIEN, a reduced risk of coronary obstruction particularly. I have something about large annuli, and maybe I'll just quickly show you this. Here's, you know, these are patients we've avoided in the past. Here's a patient with an annulus of 760. Now remember at least the SAPIEN valve 29 has an area of about 650 millimeters currently. So this is quite a bit larger than the SAPIEN 329 valve, and represents considerable undersizing, but you can see how there's really sealing from the leaflets, even if not the annuli, in this particular patient. Here's an example of a patient with an annulus of 821. implanted with an overfilled Sapien 3, making it slightly larger and really minimal leaks. One of the things that contributes to this is the sealing from the leaflets, and the other thing is sealing from the LVOT down below the annulus. And if you measure LVOT diameters, sometimes they're smaller than the annulus, and this predicts a good result. Now, when you put in the balloon expandable valves, what can you expect? And I think this is some useful information. This is us testing in-house within Vancouver. What happens when you overfill balloons plus or minus 10%? The bottom line is a 10% reduction in volume means the valve is going to be 1 millimeter smaller. 10% additional volume means it'll be 1 millimeter larger. And here's just a demonstration of this. I guess I would point out that what we've done here is actually use larger balloons. And you can make each one of these valves 3 millimeters larger than the normal. You can make a 23, a 26, a 26, a 29, a 29, a 32. It really is possible if you just have a large enough balloon. But do you want to do this? I think it's important to understand what can happen. You can stretch the leaflets so they don't coact properly. You can tear them. But this is really primarily a problem with exaggerated enlargement. And it's more a problem with the small valves, the 23s, maybe the 26. The bigger the Sapien type valve is, the more you can stretch it bigger. You have enough redundant tissue that you'll do excellent with this. What happens when you overspan with progressively larger non-compliant balloons? Again, you are going to get 3 millimeters extra size. Here's some in vitro work we did in Vancouver on overexpanding these valves. And there you can see the 29, even when it's dilated 3 millimeters bigger, 2 or 3 millimeters bigger, it's perfect coaptation. 26, taken to 28.9, not so much. 23, taken to 26, no, now you have a central leak. So you can get away with it much better with the larger valves. And even on this table, we're showing the regurgitant fraction. The regurgitant fraction is still excellent in a 29 valve taken to 32, 31, 32. It's still within recommended guidelines. The 23 and 26, not so much. You can't go quite so far. I think I'm going to stop rather than talk about bicuspid valves, and maybe we'll go on to the live case if we're ready.
David is going to go next.
No, David is going to go next. You know,
They extended the satellite time.
Okay, so David Cohen is going?
Yeah, David will continue.
She just said, so go ahead, please.
Okay, so I'll skip the last bit of my talk.
Can I take your Coke?
And David Cohen is going to talk now, and then I guess we go live to Vancouver.
It's a little erratic, so apologize, because we were going back and forth, and now they told us to keep going with the talks, and then, you know, we do the live case. So, David, quality of life after TAVR, what do we know? What should you care? Why should you care?
Why should you care? Thank you very much. A little bit hectic morning, but I'll try to stay on time, and hopefully we get to the live case. So why do we care about quality of life after TAVR? Maybe this is self-evident at this point, but I think for our inoperable patients, we know there was a big survival benefit in the Partner B trial, but for most of the patients, certainly in the extreme risk range, who are very elderly and have multiple comorbidities, improved quality of life really is their ultimate goal of care. And frankly, in the absence of an improved quality of life for many of these patients, I think most of them would probably not choose to have a TAVR procedure done and to live longer with a persistently poor quality of life. For the intermediate and high-risk surgical candidates, it's not clear whether we truly have a survival benefit of TAVR compared with surgical AVR, although the S3 trial does suggest that's possible. And some complications are clearly increased, like vascular complications, paravalvular aortic regurgitation. And therefore, when we don't have a survival advantage, then quality of life is really critical to showing an advantage of TAVR over surgical AVR. So I wanted, we've been studying this now for nearly a decade, and I just want to go through with you a couple of the key insights that we've developed over the years. The first and probably the most important one is the quality of life really does get better after TAVR, even among the inoperable patients. So this is the first study that we did in Partner B, looking at the Kansas City Cardiomyopathy Questionnaire, the KCCQ, the overall summary scale here, which goes from 0 to 100, and you can see the TAVR group in blue and the control medical therapy group that was getting a number of balloon valvuloplasties, and you can see there was a very substantial improvement, as well as statistically and clinically important differences between the groups at each of the time points. And just to kind of frame this, for those of you who are not familiar with the KCCQ, again, this is a scale that was originally developed for heart failure, but it works very well in aortic stenosis, and we've validated it now. And this really shows what the changes are that patients can perceive. And very importantly, there are some metrics here. So a small change in the KCCQ is about 5 points, a moderately large change is 10 points, and a large change is 20 points. And if we look here at the KCCQ summary score, again in Partner B, inoperable patients, and we look at the patients who improved substantially, what proportion of them got a 20-point or larger improvement, you can see it's a large fraction of the patients, the majority of patients got at least a 20-point improvement, and much larger than was achieved with medical therapy and balloon valvuloplasty. So clearly a major benefit. And then if we look at the generic scales, this is the SF-12, the physical, the mental scales, these all improve as well. And this actually can give us some very, very interesting insights. So if we look at the SF-12 physical scale, you can see at 1 year in the Partner B trial, there was about a 5-point difference here. And what that 5-point difference actually is comparable to, if we look at other studies, external studies, is about a 10-year difference in age. So it's almost like we turn the clock back about 10 years for these elderly and very sick patients, which is really quite remarkable. So that's the first important insight. The second very critical insight, I think, for the whole field of TAVR is that the quality of life benefits are durable among the surviving patients. Obviously, we don't know what the quality of life is among the patients who die, but these are data that we published last year from the core valve. This is from the extreme risk core valve trial, looking at the KCCQ over the first 3 years of follow-up. And you can see that the improvement at 12 months was about 26 points, so a very large improvement. And there was a small decline over time, but still, by the end of 36 months, comparing the patients to their own original baseline, about a 19-point difference. So again, a very durable and substantial quality of life benefit out to 3 years. We will see this year, just getting ready to analyze the 5-year data here as well. The third insight, which I think has also been a very important one, is that although on average, as I've just shown you, the quality of life does improve substantially, on an individual level, there is still considerable heterogeneity of benefit. And what do I mean by that? So here is the proportion of patients, again, looking back at Partner B, but we can see the same thing in Partner A or in Partner 2. This is the proportion of patients who achieved a significant improvement, a 10-point improvement in the KCCQ. And yes, it's a very substantial amount, and yes, it's larger than the proportion in the patients who were treated medically, but still, if we look at 6 months here, about a quarter of the patients who survived did not achieve a meaningful quality of life benefit. And that is obviously of some concern, and if we could identify those patients at the time before the procedure, perhaps this is a group of patients for whom TAVR would not be recommended. Perhaps those patients are better receiving palliative care or simple medical therapy, that we're wasting our time, our money, and exposing them to complication risks. And we actually spent quite a bit of time over the last 5 years or so trying to develop new approaches to understanding and predicting who those patients will be. And then the last point that I want to make, I think has been one that to me was somewhat of a revelation. It was not something that was intuitively obvious to me when we started, is that less invasive procedures don't always result in better quality of life. And what do I mean by that? So here is the Partner A trial. TAVR compared with surgery in high-risk patients. You can see the TAVR group. Again, the quality of life scale in the light blue is TAVR. Surgical AVR is the yellow scale. And you can see there was a benefit of TAVR early over surgery on the KCCQ summary score. It was statistically and clinically important, but no differences at the later time points. But what was, and all the patients improved substantially by 26 to 30 points. But the key thing that we noted when we did this analysis, and remember this Partner A trial, about half the patients got alternative access. In this case, it was transapical access. There was a significant interaction between the treatment benefit between TAVR and surgery and the access site, both for the KCCQ as well as all the other endpoints that we looked at. And what I mean by that is if we look now specifically at the transfemoral subgroup, and what we're summarizing here is the difference between TAVR and surgery at each time point. And you can see in the transfemorally treated patients, there was about a 10-point difference at 1 month, no benefit of TAVR over surgery at 6 months or 12 months, but a very important difference at the 1 month time point, which is a key and really why TAVR patients want to have TAVR, because they want to get this benefit. But when we looked at the other subgroup, and recall that the randomization in this trial was stratified, we actually saw no difference in quality of life between transapical TAVR and surgical AVR at 1 month, at 6 months, or at 12 months. If anything, there was a little bit of a worsening of the quality of life. And this is not unique to the Edwards valve. It's not even unique to transapical access. It also holds for the core valve and for direct aortic access. So this is the high-risk core valve trial, came along a few years later, and again, we're looking at those same things. The difference between surgery, TAVR and surgery, the transfemoral group is shown here in the blue, and the non-iliofemoral group, which was mostly direct aortic with a little bit of subclavian thrown in this trial, in red. And again, you see this strong interaction and this big difference at the early time point. So the transfemorally treated patients derive benefit, and there does not seem to be a quality of life benefit from the patients who got alternative access. And when we first started seeing this, we kind of scratched our heads and said, why would this be? It's less invasive. They don't go on the pump. They have a smaller incision. So one thought was, well, maybe the non-iliofemoral patients are just different. And the best TAVR candidates were selected for a transfemoral approach. And that, to some extent, is true. But if that were the case, then what we should see is that surgery patients who were treated, who were not eligible for transfemoral access would have done worse. So this is the TAVR group. And now we're not doing a randomized comparison here. We're actually comparing the two access sites. So this is, again, from partner A. The transfemoral patients are in blue. The transapical patients are in yellow. And you can see a big gap here at the early time point. But what happens with surgery? The surgery patients actually, whether they were eligible for transfemoral or whether they were only eligible for transapical, they did the same. So this to me suggests very strongly that it isn't that that these patients, the transapically treated patients, are doomed to have a worse quality of life. It really is the fact that it's a different procedure when we do it transapically. A second possible explanation for this is, well, maybe we were just inexperienced. Maybe as we got better, things would improve. But actually, we've seen exactly the same results in the Partner 2A trial, again, where we looked at both transapical and direct aortic. We saw the same exact thing, which was no quality of life benefit with TAVR, even at the early time points in the patients who could not be treated transfemorally. And so I think the most likely explanation for this, and the lesson we've learned, is that less invasive is not necessarily less painful. It doesn't necessarily improve quality of life. And I think if we talk to our cardiac and thoracic surgical colleagues, they would tell us that their experience had suggested to them that a median sternotomy, the surgical incision for surgery, is generally less painful than all other forms of thoracotomy. Why is this important? Well, I think it's really important as we think about transcatheter mitral valve replacement, because transcatheter mitral valve replacement, as we know, many of the devices right now are transapical devices, and I think this tells us that we are not going to expect major quality of life benefits until we can get these devices to be able to be delivered through a non-thoracotomy type of incision. So just a few summary points then. For the extreme risk in inoperable patients with severe aortic stenosis, TAVR provides substantial and sustained quality of life benefits compared with medical therapy alone, no question about that. For both high-risk and intermediate-risk patients who we've studied in the trials, transfemoral but not transthoracic TAVR provides an early quality of life benefit compared with SAVR, and similar late quality of life. And we need further studies to really tease out a few of the more critical issues here. In particular, we need to do some studies to really understand the long-term, the 5 to 10-year durability of the quality of life benefit of TAVR versus surgical AVR, and we will have some 5-year data coming out this year from the core valve trial. And then very importantly, a real focus of our research of trying to identify the patients who are not going to benefit. Thanks very much.
Thank you, David. I think they're ready in Vancouver, so maybe we'll go straight there. As I think Anson Chung may have play. Maybe we skip this if it won't play. Should we go directly into the room, please? Nope.
Well, good evening here and a good morning in Seoul. Welcome you to Vancouver. We're going to show you a very interesting case today. I apologize for the delay in terms of the transmission, but we're already in the surgical here about an hour now. So I'd like to introduce everyone in the room. I'm Anson Chung, the surgeon here. Rob Boone, our interventional cardiologist. We have Dale Murdoch. He is our interventional fellow. I have my fellow here, Wei Wang, who is a surgical fellow with us. And we have anesthesiologists. We have Simon Bruce. We have Jasmine Gwitwall as our echo expert. We have our scrub nurse, Livia, and circulating nurse, Kieran and Grace. We also have James from Edwards to the clear mouth valve, and John here to run our X-ray. So why don't we go straight to show you our case, and then we can have a more discussion after that. Dale, please.
Good morning. So Mrs. UW is an 83-year-old female. She presented recently with severe bioprosthetic mitral valve stenosis on a background of triple valve surgery in 2013. So she had 25 millimeter perimount mitral valve replacement, a 21 millimeter bioprosthetic aortic valve replacement, and tricuspid ring annuloplasty in 2013. Along with ASD closure and pacemaker implant, all in the one procedure. She did very well for 5 years. Next slide, please. And has recently presented with NYHA class 3 heart failure symptoms and a reduced 6-minute walk distance at 244 meters. Her comorbidities include atrial fibrillation on warfarin, cerebrovascular disease, and stage 2 chronic kidney disease and hypertension. Next slide, please. So our non-invasive imaging first shows with echocardiogram an ejection fraction of 70% with comments about a small left ventricle with an internal diastolic diameter of just 44 millimeters. And there's very clearly severe bioprosthetic mitral valve stenosis with a mean transmitral gradient of 25 millimeters of mercury. There's only mild, there was no mitral regurgitation on the transthoracic, and we note mild MR on the TE today. The bioprosthetic AVR is working well, as is the annuloplasty repair. She also had a pre-procedural CT of the mitral valve to assess the neo-left ventricular outflow tract. And you can see on the below images there that there's a virtual 26 millimeter Edwards SAPIEN 3 transcatheter heart valve in the valve-in-valve position, giving us an estimated neo-LVOT of 1.7 square centimeters. Next slide. So in summary, we have a high-risk 83-year-old female for elective transapical transcatheter mitral valve in valve implant, and her STS score at time of discussion at the heart team meeting was 9.95%, so clearly high risk. And we're planning to use a 26 millimeter SAPIEN 3 in the 25 millimeter perimount bioprosthesis. Thanks, Anson.
So great summary, Dale. We'd like to, Jasmine, why don't you give us a tour on the echo finding on this patient, please?
Sure. So we'll start off with the transgastric views, and here you can see that there's a normal left ventricular systolic function. The ejection fraction is in the 65 to 70% range, and as already commented, the LV cavity is small. Similarly, the right ventricular function is also normal. Again, from the transgastric view, we're zooming in on the 21 millimeter bioprosthetic aortic valve. You can see where my arrow is. And the mitral bioprosthetic valve sits here. You can see that the leaflets are opening normally and that the LVOT is clear of any of the mitral valve prosthesis. You can see the outflow there across the aortic valve, and we have a mean gradient of approximately 11 millimeters of mercury across that aortic valve. Moving on to the mid-esophageal view, you can see here the tricuspid valve, the annuloplasty ring. The leaflets are opening normally with no evidence of restriction. And there's mild to moderate tricuspid regurgitation in this view. And now we're focusing in on the mitral valve. We'll have lots of images of that, but you can see that one of the leaflets is restricted. You can see that there's flow acceleration at the level of the mitral valve with mild transvalvular prosthetic regurgitation. No evidence of paravalvular regurgitation in any of the views. We have a mean gradient on TEE of 12. Again, rotating through around the mitral valve, you can see flow acceleration, minimal regurgitation across that mitral valve. And here we have a long axis view. You can see the aortic valve in this view is also opening normally. And again, the prosthetic valve is clear of the LVOT. It's a 3D view of the bioprosthetic mitral valve, and you can see that the leaflets are in fact restricted. And again, just going back here, short axis view of the aortic valve, opening nicely. A better, nicer view of the tricuspid valve, also opening nicely. And so now if we zoom in on that mitral valve, I think it's even clearer that this one leaflet is quite restricted. And again, going around the valve. Significant restriction with mild regurgitation and flow acceleration at the level of the valve. That's it.
Well, thank you, Jasmine.
So, Anson,
do anyone have
valve,
on the panel or the audience have any question regarding
can you hear me,
the
Anson?
case or regarding to the echo images?
Can you hear me, Anson? Guys, I don't think they're hearing me.
Yes, absolutely. Yeah, I can hear. Yeah.
You can. Oh, so you have a
Yes, I can.
You have a 25 paramount valve. The ID.
I can hear you. I can. Yeah.
The ID is 23. Would you think of using a 23 implant?
26.
Sorry, would you think of using a 23 implant and a 25 paramount? You could expand it to 24. Just a question.
Yeah, so that's right. Yeah. That's correct. So we have this is a Magna East actually. The internal diameter is actually 24, not 23. So that's why we picked the 26 for this particular case.
Now, if you take a 26,
different version of the Paramount valve, the older version with the 25 millimeter could measure from 22 up to 23 millimeter. The Magna East in general is a bit bigger, so it's about 24 millimeter. Yeah. In the past, we have actually implanted a smaller sapien valve in, and we have seen late migration of those valves if you're not overexpanded a bit more. So that's why for safety and preventing late migration, we'd like to implant a bit bigger version.
I think that case of your late migration of a 26 valve is actually embedded in Vinny's app. If anybody wants to look at it.
David just gave a talk and to give transapical a really bad name. So I'm just gonna give you a tour of what we do here. Can you just zoom into the incision here? I guess, it all depends on how you do your transapical and how big of a thoracotomy you're doing. So, I mean, traditionally, we are all here that when we do our apical from day one on, from 2005, we do a tiny 2 to 3 centimeters incision. Most of the patient will get epidural or perivertebral block or local block prior to the incision. And we don't use any whip spreader. I mean, this is the pain of this patient. There's no doubt it's some pain. No doubt we cut muscles, but not excessive like a lot of other people if you put a retractor in.
Can I ask a question?
And in addition, we extubate our patient right on the table in majority of the cases, and the patient don't get a Foley catheter, and they mobilize quickly right after the case. And usually we have in most of the cases now go home in about 2 days after the implant. So I mean, hopefully, it all depends how you do it too. It's not just not apical.
Anson, we had a question from Maurice.
Can you hear us, Anson?
So why don't we show a couple images because we are so a bit anxious. So
can we let them know
because
we have
of
a problem
time,
with them hearing
so
us?
I actually crossed the valve already with a soft wire and then a 7 French. So can you hear what I said? Or
yeah, we can hear. We can hear you. Can you hear us?
Did we lose transmission? Yes, I can. Yes.
Can you hear us? There's a delay, but it's like...
No, I'm hearing only some muffling in the background.
Yeah.
Now I can, yes.
All right. So, Ansel, it's Maurice Bookbinder. Can you hear? Nope.
Yeah, I just got a text. There's an 8-second delay.
I see.
So I think that might be
Yes.
the problem.
Hello, Barry.
Anson,
Yes,
why don't you just go ahead?
You know, you shouldn't send this to North Korea first. Send it directly to South.
So while he's working, John, what is...
Okay, very good. Okay, so why don't we, well, so we have closed the valve already, so I'm going to exchange it to a M-plex extra stiff wire. You can go zoom in
So
here and then go
the key
to
here when you're
fluoro,
going
please.
apical is not to get under one of the cords or trabeculi or something. And so he's very careful to make sure he has a clear path to the valve on ultrasound. He'll typically look at ultrasound.
So we're now just putting
He'll push and pull the wire and make
M-plex
sure that it
extra
doesn't
stiff
look like
wire,
it's trapped under
and I'm going to
anything.
take out my 6 French catheter. Prior to do that, I'm going to show you the delivering system. Right here, please. So this is the center-tube system that we've been using for the Sapien 3. Now the initial system we used for transapical was 33 to 34 French in the past. Now is much slimmer, down to 18 French. So the trauma to the apex is much less, and the bleeding postoperatively, we have not really have any problem with this smaller delivering system. So I'm going to do is I'm going to take this 6 French out and then put this new catheter in, the introduction to sheathing.
So since he can't hear us, John, maybe you can answer. Why transapical rather than transeptal?
So we in general give heparin enough to get an ACT about 300 seconds.
So I have to say I did last week I did 2 transeptal mitral valves as well.
There was an ASD repair.
We did the first demand transapical mitral valve and had very good results. In our first 67 patients, which we reported last year, there was 1 mortality with the transapical procedure. So the results have been fabulous. They're also fabulous with the transeptal. So we have 2 fabulous procedures.
Yes, that's why I was trying to
and
say,
so
is there something particular to
well,
this case?
one thing that's particular is I'm here. And Anson's there. So that limits our options.
Yeah.
But there was also an ASD repair, so maybe...
But the results are really superb anyway.
So this patient had an ASD repair following the previous procedure?
So very good. So I'm going to introduce the delivering sheath through the valve. Can you use a screen, please? There you go. So again, we would like to do least traumatic as possible. Just rotate the sheath in, and we leave it about 3 to 4 centimeters right at the incision, and I'm going to take the...
So you see how this is a very stenotic valve, so we pass the dilator through the valve to dilate it just a little bit.
Yep.
I like to pack the stiff wires in the top of left atrium, not in the pulmonary vein. The reason for that is that if you pack it into the vein, you will fix the axis of your direction of your valve. And it's actually not as important for mitral valve in valve, but it's very important when you do if you do a transcatheter transapical mitral valve replacement.
And what kind of wire do you use? Like
so we're going to bring the valve up, and we do this traditionally. Is that we put the valve into the wire, and then we check the direction, and we confirm with at least 3 people to make sure that we did not flip the valve around. So we can probably zoom in here to see. So you can see this, the valvic cuff is distal. That means it's atrial side, and in the transapical mitral valve, this is the right direction. So Rob, if you don't mind, just straighten that wire and then push in the valve for me, please. Yeah, right here. There you go. I got that. Just control the wire. That's good. You don't need to screen. Yeah. So first thing, I need to just de-air the system. That's very good. Okay. Now, can we get the pacing ready, please? So I will get everyone all ready before I cross the valve. You don't want to be, you want to minimize the time that you need to obstructing the valve. So live echo, please, with explain. Very good. Okay, your pacer ready? Very good. So can you screen, please? So we want to make sure the delivery system is coaxial. We can make up one.
I think one advantage
so what we like to do is to put the valve, the CPN3, 1/3 in the atrial side and 2/3 in the ventricle.
Which is always a problem from transeptal.
So I'm going to...
And when it is severe stenosis like this, the transeptal sometimes gives you a very difficult alignment.
there are a lot of tricks to the transeptal to get to coaxial, but you can usually achieve it. But early on, it was a very big problem.
Yeah, for me, with the stenosis rather than regurgitation, many times it's because of regurgitation, and rarely it is because of severe stenosis like this one, and that's where the alignment becomes a problem. I don't know what the left atrium size is, but combined with the very large left atrium makes it to even more difficult with the transeptal.
Just tell me when you want to see me. Very good. So I'm about to cross the valve, so you can screen for me, please. So now I'm going to go up. Now, also this transapical system does not require to get pull the pusher back. So there's no such thing. So it's much less in terms of stepwise. So what I like to do is, again, we like to implant about 1 foot atrially and then 2 foot into the ventricle. So that would be a good starting point. So let's just look at echo 2. The echo is actually giving us a very beautiful image. Jasmine, would you like to put a cursor on the shoulder or the end of the distal portion of the sapien valve so people can see that on your echo?
So I think generally you want...
Right. Can you guys see that? So this is a good starting point for me. And then what we're going to do is going to get a pace. So when the heart is more stationary, and then we will decide that we're going to deploy the valve or not. So
transeptally, we usually just put the outflow 3 millimeters distal to the posts.
So
we pay very little attention to the atrial component because it shortens up.
Okay, very good. So I'm at 2 atrially. So now we can go up slowly.
Going slowly.
So I have very fine control to control where the valve is going to land.
Slowly.
So you can go all the way up now. There you go. Very good. Excellent.
I think that's
very
just
good.
perfectly. He's going to have
very good.
Sort of
very good.
supraannular
on,
function
please.
with
I'm going to pull this balloon back.
So it's a very small surgical valve, so hopefully the hemodynamics will be good with that.
So we like to actually start at 1 foot. I would like to have bare minimum into the atrial. We have in the past, we have done 60, almost 70 something cases now here. If you leave too much of atrial skirt into the atrium, we have clot forming. So let's go to echo for now and then see if we have a good result.
Yeah, so you can see here on the left screen that the mitral valve leaflets are opening beautifully. And there's nice laminar flow on the right-hand side there. We're not seeing any transvalvular regurgitation, just the normal regurgitation sort of washing jets that you see on the side, the intravalvular ones. Going around, again, opening beautifully. We'll get a gradient in just a second. But looking really nice.
Very good. So one of the things that we always do, we like to see this wedge shape in the different valve. The main reason for that is that the pressure is actually from ventricle to the atrium. If you get this wedge shape, the likelihood of having a late migration is virtually none. So you guys have any comment on the panel or the audience?
Well, it looks like very nice positioning. I mean, because the gradient's LV to LA, I think you're quite secure there, and you should have really good leaflet function because it's above the ring, the leaflets should be, I think. It'd be interesting to see what the gradient is. One of the questions we had when we discussed this case was whether we should put in a 26 sapien valve and then crack the ring to get a better mitral valve area. That's a kind of a small surgical prosthesis in there. What would you think about doing that if the gradient were significant? Would you be comfortable or no?
Yeah.
What would you think about doing that if the gradient were significant? Would you be comfortable or no?
Well, I think that this lady, I mean, she had a very good, function for about 5 years with the size of valve, 25 millimeter valve. I think if we can give her, she's now 83. I think we give her another 5 years with this. I think I'm satisfied with that. The other thing is that her LVOT calculated on end systole is 1.7. If you crack it and then potentially expand the sapien 3 even further out, you might actually decrease the LVOT even further. So in her particular case, I'm not very keen of doing a post-dilatation or cracking the valve.
And you think by cracking it, you would go to 29, just kind of knowing the dimensions, or? what would you do? I mean, what's
Oh, no, I would, well, I think I would do the same thing as Anson's saying, but I think it's a question we should be asking now. If somebody has a very small mitral prosthesis, we can make them bigger, and maybe sometimes we should. But I think his point about the low neo-LVOT predicted from CT is a real issue, that why take a good result and get LVOT obstruction that you can't fix
this is wonderful,
surgically. So it looks like she's going to have an excellent result. That interested to see what the gradient is there.
We all try very hard to do the transeptal, but I mean it's so difficult to make statements that this is really not so much easier.
I mean, as you can see, it's really a pretty good procedure.
Exactly.
Yeah.
It's hard to make a huge argument when the LV is preserved.
I think this
So just for interest, the pre-op transthoracic was 25 gradient. The TGG gradient pre-implant was 12. Now we have a 4 millimeter mercury gradient after the valve-in-valve. So I mean that is a very good result. I mean I couldn't even say that I have the same result replacing with a surgical valve again, with virtually no paravalvular leak. So I'm we're very happy with the result.
Yeah.
Great.
Well, perhaps we'll just see the sheath come out.
What I'm going to do is I'm going to just take this central tilt
and then we may go to the second case, because I know we're late.
And actually, why don't you pull the wire back first?
John, and could you make a comment on the positioning? Because the valve shortened, so it's basically everything is within the valve. Is that your ideal position?
Well, I think it really is ideal to have it just at the valve ring, because the forces are pushing it into the atrium. I think, though, the problem is if you try and position it that perfectly, you take the risk you might have it too high, and then you're going to embolize the valve. So he cut it very close.
So I'm going to show you the
I think it ended up perfect. I probably would have aimed a little more atrial just to give me more room for error.
Horizontal metro sutures on it.
But there's no real need to flare inside the atrium.
And there's absolutely no bleeding at all. The area that encompassed by this is only about 1.5 centimeters in a square, so it's hardly any, damage to the ventricle itself.
That's really superb, Anson. Any other thoughts or comments from anybody?
I have a comment about your question 23 versus 26. I think it's a very important question because, as you know, the height of the valve is not the same. So the compromise of LVOT can be less with the 23 as compared to the 26. So I think it's really a very important question for this particular case because
so I'd argue that the length doesn't matter that much, because the last cell of this sapien 3 is open anyway. What really causes LVOT obstruction is the surgical leaflets. And the reason the 26 is worse than the 23 is because it pushes them out further, not so much because it's longer. But the other concern you have about underexpanded 26 here is that it's reasonable to think maybe there's a high risk of thrombosis if the valve is underexpanded. It's reasonable to think maybe there's less durability if the valve is underexpanded. But this is an 83-year-old woman. I think she's going to get more than enough durability and functional benefit.
And migration, even it doesn't have to be in the left atrium.
Easier to position, which is a big issue, particularly with transeptal. Well, Anson, thank you very much. Maybe we'll leave you there and move to
yes,
David
in
Wood's
addition,
case.
just to make a comment on that, is that you see this is a 26. This is not underinflated. This is a full 26 inflated. And you see that it's actually the ventricular portion is not even wedge-shaped that much. So if you use a 23, I think you probably have to add a couple of cc's, 2 to 3 cc in order to achieve the same result. So I think this is definitely safer. With our previous experience with migration of a valve into the left atrium, I would cautious using too small of a valve in a mitral position. Aortic a bit different. Aortic, I think, as the valve is seeing the diastolic pressure, not the left ventricular systolic pressure. So the stress on the system is very different.
Anson, is this patient in sinus rhythm, and if so, what would you plan for anticoagulation after the procedure?
I thought they said there she was on anticoagulation.
Very good.
I think it's...
So we have the past experience of having either the clot forming on the left atrial side if you have too much skirt, too much valve hanging out, and also the having leaflet thickening. So we've been doing is that we've been doing at least 2 to 3 months of Coumadin and aspirin. Doesn't matter what rhythm they are on. If they are, of course, in atrial fibrillation, we will leave them on lifelong anticoagulation. After 3 months of Coumadin, if they were on a NOAC, and we'll switch it back to that for long term.
Are they ready in the other room? Are we ready to go to the next case?
So I just, not quite yet. So we have a very interesting case also up in the cath lab with David Wood. He needs about 10 more minutes to get prepared. So we have a little bit more time for discussion here.
Okay. Okay.
John, I have a question. If you were to crack the valve, do you use this balloon? Do you oversize the balloon? Do you
So
take
why
a
don't we do
different
that
balloon?
in the meantime? So why don't we, why don't we downstairs, can we show the slide of some of our local results for the transapical mitral valve in valve? Thank you. So, you know, I've looked at, I guess last year, it's like 1 year old now, we looked at our first 67 consecutive mitral valve in valve cases done apically.
Can we get those slides
Of
up,
course,
please?
John had mentioned that we have done many transeptal approach with very good success. I'm just going to show you our own data. Can we put up the slide, please? On the screen here. So you can see that, you know, this is the typical patient that we treat, mean age of 80. About same, half and half, male and female. A lot of people have a lot of previous problems, stroke, a third of them, COPD, chronic renal insufficiency in 6 out of 10 patients. All in class 3 and class 4. Gradient across the mitral valve pre-implant is about 12. Most of them had good ejection fraction, high peak pressure, and very, very high STS estimated score for mortality at 30 days at 12.4%. Next slide, please. So we have done many procedures, and this is the most common one that we have implanted is the Medtronic Mosaic, followed by the Perimon, then by the Carpentier Edward porcine, and then St. Jude epic valve. And we have most of the patient has sort of 1/3 mix of mixed etiology, 1/3 regurgitation, and 1/3 stenosis. Valve sizes, the biggest we have done is the 33 millimeter Mosaic, which we use a 29 sapien 3 for. Next slide, please. So we have only one single procedural mortality in 2009. And that was the patient that we have LVOT obstruction post-implant. We have absolutely nobody talk about LVOT obstruction post-mitral valve at that time, and unfortunately, I suffered one of those losses. And the patient suffered the most loss, obviously. So out of those, we have one patient that requires second valve implant. Conversion to surgery was that only patient with LVOT obstruction, with implant success rate almost 100%, 30-day mortality, 2 patients out of the 67. And 1 year mortality, 8. So the 88% of the patients survive the 1 year. We have the 30-day stroke risk of 3% of the patients. Next, please. So those are our apical results. And you know, there's no doubt that you can do this apically and septally. You know, I think apically is quite straightforward and have really better control. But however, you know, that both ways, will do patient quite good, quite well.
So
and just locally, you know, we have high apical numbers because we have such a, good result, for all since 2007.
When do you think transapically is not indicated? For example, is there an LV status that you think it's better to try transeptal, or there's no such thing?
Well, you know, definitely the contraindication for apical, I think to me, I have done apical in patients who had a previous LV aneurysm repair, previous door procedure, and previous actually apical. We actually put in a third valve in another patient. With that migration of the valve, actually we came back apically to do it. So, I mean, there's definitely some contraindication. I think LV thrombus will be one. Second will be a radiation chest. We've absolutely no rib space. those patients are terrible for wound healing. So I would stay away from those patients. Obviously, you have patients that with very, very large breasts and if we have infection under the breast, those things I would like to stay away from.
Anson, you've had a fair bit of experience with double valves. Can you talk to us a little bit about that while we're waiting for the other lab? Aortic and mitral transapical.
Sure, that's right. So out of the 67 valve we've done 9 double valve of intubation with either native aortic stenosis with mitral prosthetic problem, or patient had the aortic and mitral prosthesis both fail at the same time. So we've done 9 of those cases, and then we have actually 0 mortality in all those 9 patients with the double valve. The long-term results is also very good. Actually, we also had no 1-year mortality in any of those double valve patients.
Now, one of the advantages of the transapical is there's certain transapical mitral valves, and you have a lot of experience with the Tiara. Can you just summarize that for us?
Well, we have to, very good success with it, and overall we've done 19 patients in Vancouver here. Actually, I just did 2 last week. Went very well. And then we have, in worldwide wise, with the Tiara, that we've done 56 cases. And our results, for the whole overall is quite good. We have now about 6.5% fertility mortality. It's probably one of the best among all the prostheses out there. This patient is the difficult group of patients, no doubt. That group of patients usually have very low ejection fraction with functional mitral regurgitation. So looking after them to get them back into the functional capacity is a problem. Though we have started doing this in 2014. We have a patient now, the second patient that we use the Tiara valve on. It's been 4 years and 4 months out from, 4 years and 2 months out from the implant. A patient with 20% ejection fraction, severe mitral regurgitation, and was referred for me for transplant. Now she's not needing a transplant. She's been from class 4 with admission needing inotrops, now has not had a single admission since the implant for more than 4 years ago. So I think that picking the right patient is still, I think, the key. I think the procedure, no doubt, I think now is apical. There's definitely the delivering system in majority of those valves are still quite big. So, the apical access could potentially see a problem. But I guess, as you all know, that I think eventually we all got to go transeptal, transfemoral venous for all those delivery for these mitral valves. Rob, any comment? Because you do a lot of mitral clips and things. And you see how you feel in that area?
5 minutes. I don't think we're able to hear the other operator.
Sorry, might need to wrap it up.
Sure, yep.
Is your mic working?
Yeah. Just finishing. Okay, very good. So, well, thank you for coming into our operating room in Vancouver. We have a very good case also coming up by David Wood upstairs in the cath lab. So I would say goodbye to you all, and you have a great day.
Okay, thank you very much.
Thank you.
Oh, do we get to see the skiers again?
There's no leak.
Good afternoon, David.
Hello, can you hear us?
We can.
I can't hear anything in my ear, Don.
I'm here with co-chair Eberhard Grube and a panel, and are we getting audio through?
John, I'm assuming you can hear me. Can you hear me?
We can hear you fine. It sounds like we're not...
I can hear you now, John.
Okay, there may be a long delay. Why don't you just go ahead, David? Just go ahead.
Okay, I'll just introduce everyone in the room. I've got Abdullah. Dale's going to be joining us. Ron Ree is on anesthesia with Connie. I've got Nalini, who's going to do an echo for us, hopefully at the completion of the case. We have Nicole on x-ray. In nursing, we've got Javier, Jeff, Jennifer, and Michaela. And we've got James here as well. I don't think I missed anyone. Abdullah, did I do okay?
I think you did well.
Abdullah, why don't we put up the slides, Don, and we'll go from there.
Sounds good. Hello, everyone. So the case we have for you today is an 81-year-old gentleman, and we're planning to do a transfemoral TAVI aortic valve in-valve implantation.
Can you put picture in the room in the
with
corner,
intentional fracture of the surgical 23mm magna bioprosthesis. This gentleman past medical history is significant for coronary artery disease. He underwent bypass surgery back in the past
picture in the
with
room,
a history of recent stroke and atrial fibrillation and moderate COPD. Next slide, please. His past medical history also includes diabetes, hypertension, dyslipidemia, and he's a smoker. And in terms of his presentation, he was actually admitted to hospital and was transferred to our hospital with acute decompensated heart failure. However, over the last few months, he's having worsening dyspnea with New York Heart Association class 3 symptoms. Next slide, please. In terms of non-invasive investigations, his echo showed a normal left ventricular ejection fraction of 60%. His aortic valve looked severely stenotic and calcified with a valve area of 0.6 centimeters squared with a mean gradient of 43 millimeters and mild to moderate aortic regurgitation, as well as significant functional mitral regurgitation. Pre-TAVI planning CT showed virtual valve to coronary distance of 3.7 millimeters for the left main, which is borderline high risk for coronary obstruction, and 6 millimeter on the right. This is simulating a 23 transcatheter valve. With regards to iliofemorals, there was significant tortuosity as well as calcifications, and maybe Dave will talk more about this with regard to our access today. We were planning right femoral access, so there was heavy calcifications that we had to switch the plan today. With regards to invasive coronary angiography, he had 2 vessels disease. However, he has patent grafts with limit mid-LAD, vein graft to diagonal, and vein graft to RPL. So it's somewhat protected left main, however, his circ is not protected.
What are we up to now?
Next slide, please.
Okay,
so in terms of we plan to do aortic valve in-valve using a 23 millimeter inside his 23 magna bioprosthesis. We suspect that the transcatheter valve will be underexpanded and we're going to have higher gradient. So we plan to do mean gradient pressures after the transcatheter valve implant, and we plan to fracture the surgical valve using a non-compliant true balloon. You see the pictures there. We have a true internal diameter of 21 millimeter for the magna valve. So I'm pretty sure the transcatheter valve will not be fully expanded. What do you think, Dave?
And Abdullah, his mean gradient was down in the mean 20s after the surgery.
Exactly.
And it's now up in the 40s, correct?
Exactly. So there's element of patient-prosthesis mismatch
right at the beginning.
From the beginning.
Go to the next slide, please, Don. So we hope these will be our teaching points here. Valve modification with intentional fracture can be done. High pressures with a non-compliant balloon is needed, and we'll show you that setup that we've been using here in Vancouver. And then very curious with the panel there, indications, optimal paraprocedural and post-procedural anticoagulation. Are you there with Everhart, John?
I am. Can you hear us?
I can hear you now, yes.
I think there's a huge delay. It's about 10
Everhart,
minutes.
I'm wearing your cologne.
So you should just go ahead, I think.
So John, why they do...
We'll discuss amongst ourselves because the delay is too long.
Nicole, can we put up the fluoro? Show me the last 2 cines that I did. So this gentleman had an outside, go back to where I was putting the large sheath up. And the name's off the case here. So you can see there was tremendous calcification. We had to use sequential dilators. Okay, you can go back to the root shot now from last time. We were able to get up the 14 French E-sheath on the other side. We were hoping that all that calcification we saw on the CT, can we do picture-in-picture, thanks? We were hoping all that calcification we saw on CT was just artifact and blooming, but it actually was real. So we used ultrasound guidance. We spent a long time. We now have nice hemostasis. We've got our sheath. Can you just show the layout here? So we've now got our large sheath on the left, even though it had significant calcification down at the femoral access site. We've got an 8 French monitoring on the right. We have our pacing wire here. And again, just to challenge ourselves, it looks like we will be crossing live again here, Abdullah, with good. This stenotic valve. Okay, great. We're going to go ahead here. We've given heparin. Ron, what's the ACT? Go ahead.
It's stuck there.
What were you saying?
David, I don't know.
Okay, so our ACT is therapeutic.
This is Eberhard, but my question
so
is...
So picture-in-picture now, you're going to have the fluoro big and the room small, please.
Would that be independent of the gradient? Suppose you have a good result.
Straight to Rumo.
Was that the angle we had before, Nicole? I thought we came over a little bit more.
Plan crack the valve. I don't know the right answer to this. We don't really know what the risk of this is. The risk seems to be very, very low, but I'm not sure that it's zero.
I think to deal with the question that you said.
So with the delay, I guess, can you just turn it up so I can hear John and
prosthetic implant,
Eberhard?
Right. Depending on what the ultimate gradient is, go with it or not.
That's right. So, yeah, that's why he said planned fracture, I guess.
But you could do planned fracture before the transcatheter or after the transcatheter.
You know, the problem is if you do it before, you may have sudden and severe aortic insufficiency. We saw this early in our experience with TAVR, where we thought we had to pre-dilate. And just dehiscing one of the leaflets, and suddenly you have a patient in cardiogenic shock.
Yeah.
So I would be very concerned about fracturing before.
So he's doing it after the implant?
Yes, that's his plan. So I think, I don't know how to think about this, but one way to do it would be to implant and see if you have a gradient that's, say, over 20.
That's it. That's the point. Yeah.
Another way to do it would be to say that, you know, maybe this patient has low output and a gradient of 20 isn't sensitive enough. And I think it's reasonable to think if the sapien valve is like this, that probably the durability is compromised and the thrombosis risk is high. So there may be an indication for doing it in those patients. But
what's your thought about supraannular valve, like for example using a self-expanding in this setting?
Yeah, I think you can make a very good argument for that, and I know that many people would routinely do that with a surgical valve that's less than 23, for instance, or ID of less than 20.
You know, John, I've been thinking about this proctoring in Japan, and the Japanese surgeons, cardiovascular surgeons, they said that 89% of their valves is smaller than 23.
Is that right?
I mean, you know, thinking now, because TAF and SAF is approved in Japan, you know, I think, and they are all afraid of fracture, obviously.
Yes.
My fear is that
this
this high number of small valves, that you don't have very good results if you don't crack. I don't know what to say.
Big problem, yes. But there's a fairly high usage of mechanical valves.
You want the other wire, the straight one, the other one, or you want to switch to the straight wire?
Yeah. Looks like he's got a JR4, which our standard would be
this is another thing. You know, this is another thing. It's not that easy to cross a degenerated valve.
You think so?
I don't think it is easy. At least it takes a little bit longer, you know?
I've been embarrassed because crossing surgical stenotic valves sometimes can take you a long time.
Yes, absolutely, because, you know, there's a tenting. It's not like
And to mitigate against that, I think it's not the JR, maybe the AL to start with to give you better.
Usually that's what he would start with, is AL1.
Yeah.
So I think he may have tried that already and decided to go with the JR4. But
that's an R? JR?
JR, yeah.
We're going to switch out to the AL1.
I actually think an AL1 would be a better shape.
That's exactly right, guys. We already tried the AL1 once.
Maybe a hydrophilic wire.
Right.
That's usually what we would switch to, is treble and
but we're going to give it a try again.
Trim with straight wire.
Yeah, usually the AL with the hydrophilic, and it's the best yield.
You know, even, I mean, these guys know how to cross valves. So the surgical degenerated valves sometimes are paid for to cross.
I've learned this doing enough cases that surgical stenosis, if you can do a regurgitant valve, it's a much better live case.
Yes, very true.
And the other valve you can get into problems with is bicuspids. Sometimes they're not easy to cross either.
That's true.
But you see, he's better positioned now because you could see the jet, and he's probably able to tell where the jet is better than with the AR.
I actually remember a gym in Rome several years ago. There's a Dr. Gube who I think perforated the leaflet because he couldn't get across.
That's correct.
You perforated the leaflet, and how did that end up for you?
No, that was okay, but it's not a good way to do it.
No.
I admit. But we switched why I took the stiff end and...
This sometimes takes a little bit of luck.
Well, I think you might want to use cerebral protection for that.
Well, that's actually a question here. I was a little bit intimidated to ask that question. But, given a valve-in-valve situation, classically now in the U.S., looking at the indications, that would be one of the indications. Would you consider this here?
Well,
obviously not, but...
I can't remember a single stroke we've had with the valve-in-valve implant, and it's about 18% of our volume is valve-in-valve. It's a very, very common procedure for us. So I'm unconvinced. Maybe I'll be eating my words a few years from now and using Sentinel on everybody, but I need a bit more evidence before I do that.
Do you remember what he said about the root? Was it enlarged or was it normal root?
You can keep talking. We're just working away.
I think it was a fairly normal root. We're just going to go ahead and talk, Dave. Just ignore us for a while. And
because then it's like with the AL1, AL2.
But about this
Sounds
time,
good.
I think you'd be wondering why.
Show the root shot, Nicole.
You'd be wondering why you didn't use transeptal access or transapical.
Transapical.
It would be very easy to cross.
Actually, yeah.
No, the root, the shot that you had up there, I just wanted them to show that.
I think there is a reasonable argument for a supraannular valve.
No, show the root shot, that one there, please.
Valves, unless you're going to do cracking.
Yeah.
Has anybody had any experience with the accurate valve in this setting, which is supraannular-ish?
No.
It's not available in the States yet.
So there's it's now available in Canada. I think it's becoming available in trials in the U.S. So
it is a little bit. I mean, it is like
there's a trial starting up, but we have it freely available. So, in my experience, it is a supraannular valve. People have had some problems with the anchoring mechanism interacting with the valve post, the surgical valve post. Well, I haven't seen that.
And what we've seen is in the native, at least from cases and others, I'm not sure about the radial strength in comparison to, so it needs a lot of pre-dilatation. So in this setting with a constrained
show the
mechanical, it may not be.
This is the other concern I have, is that I found with the accurate valve, I'm reluctant to post-dilate it after because it hasn't got a lot of radial strength. It would be very easy to pull that valve out if it was. For instance, in the valve-in-valve, it might be like that.
Looks like you're going
squirt out. So I'm a little concerned about that valve, even though it would, theoretically be supraannular, maybe.
I don't know how much experience there is in general with valve-in-valve with accurate.
I had a look and I couldn't find any publications.
No. And the other thing is, if you don't place the cementus right, you're really in trouble because the valve is high. You can't get into the coronaries, and that I've seen this live. And
then I'll take the hydrophilic wire back.
They were testing to get into the coronaries. No way, because the valves, the leaflets are up.
So what's your next plan?
He's changing wires.
About now, I'd be asking the fellow to try.
We've just switched to an AL2 now because of the size of that root, just to see.
Exactly.
We've tried an AL1, a JR.
It looked like the AL2 you had room for the AL2 that will be poking at the level.
The other thing that I sometimes do in this situation, I put the catheter way down.
Looks better, actually.
And probe.
Almost on top, so I see
the jet moving the wire.
This is why I was asking about the root, because it looked like there was room for the AL2 to do exactly.
I find often the problem is that your Amplatz catheter is just too high up. See how it's very high, and he's pointing it, but it's always getting blown away. I think sometimes you have to put it right down on the valve. Now, remember, the hole in this valve is going to be right at the top of the post. This is typical of pericardial valves, isn't it? The leaflets go horizontally from post to post. If you're looking at a porcine valve, like in some mosaic valve, the leaflets dip in between the posts.
Is it the AL2?
AL2. That's the L2 now.
I think that's an AL2.
Yeah, I think the AL1 was a little better, don't you think?
I've actually had luck with the Jackie catheter.
Yeah, but it was
This is an
too far out.
AL2.
I think the AL1 was better, but, you know, I guess I would always say if what you're doing makes
Can you
sense,
put the
but it isn't
hemodynamics
working,
picture
try
in
something
picture?
else anyway.
Yeah, so this is not necessarily you know, unheard of. Sometimes it takes 40 minutes to cross. So it's not like David is doing good. But one case we had where we couldn't cross.
AL1.
So the default was to do a puncture of the apex with a small catheter, with a micro catheter.
Yeah.
And it flew out from the side, snared it, and then came back to the standard therapy once we had the sheath in place.
So I think that Jan Yi and I did the first case in China, I believe, about 2009. And when we went there, first of all, they wouldn't let the valve into Canada, into China, because it was a bovine pericardial valve, and beef products were banned. But the general who led the hospital sent his car and got it out of the airport, sort of through force. And we got a phone call at the hotel at 10 o'clock at night to come and do the case. And so we arrived, and we could not cross the valve.
Remember this.
So we did an apical puncture. We put the wire through the apex, snared it out the leg, and did our transfemoral procedure.
And you did the apical puncture cut down, or just
we actually did a cut down.
Yeah. So we could with the micro puncture set, you could do it with the just direct.
Well, I had my transapical surgeon with me, and there's no argument about this.
No reason to that. But if you get stuck, I'm just saying for the audience now, this is an option where you can get the 18 wire, then snare it, and then
put a catheter over that.
Exactly.
Yes.
And all transcutaneous.
And particularly because it's a redo, the risk of pericardial bleeding would be pretty low. Yeah. I think that makes a lot of sense. 18 wire through the apex. I don't think he's going to be doing that today.
No, we're not hoping not to get there. I'm
no,
just saying alternative of
just to be clear, it's not a suggestion.
No. It is just
John, would you even go a little bit deeper now?
I would always put the AMPATS catheter closer, because you know, one of the things you want to do at this point is maybe try RAO and LAO and see, are you too anterior or too posterior? Usually, now that's looking a little more hopeful, but it probably needs to be a little higher. Remember, there's 3 leaflets, so it's got to be closer to those 2 posts than closer than the single post.
There you go.
So I just point out, this is the view we like to use when we're implanting these valves, because the surgeon has put those 2 posts either side of the left main artery. So this is actually the perfect view of the optimal left main artery.
Dave, can you hold this?
Feed the wire, please. I can't lose wire. I'll do it now.
He doesn't want to lose wire position. One wonders why.
Yes.
He didn't say I don't want to say I cannot lose wire.
Well done.
So generally speaking, you use the what kind of wires, John?
Ron, can you tell me the ACT, please?
Well, with this valve, we still usually use an AMPATS extra stiff.
Yeah.
We find it very, very safe. We've used it for
so
putting in
that's
the
live
sheath.
fluoro.
It's fairly
Don't let
cheap.
it come back, please.
No pre-curved.
I think when we're using something like the Symetis or core valve, Medtronic, we would almost always use a Safari would be our default, because I think you use the wire differently with those.
Straight
valves.
AP, please.
You push on the wire often. Here we don't. And here we actually
but
don't
we'll go back
want
to
a
that
stiff
angle
wire.
in a moment. We'll leave the table at this height. Valve up.
So now it's very, very tight. Would anybody here pre-dilate this to get across?
I must admit,
Well, there you go, John. We wanted to challenge ourselves.
I try to do that. But
You know, when the valves are very, very tight, I often use a 10 millimeter balloon. I think there's no risk with that. And but we certainly would never use a balloon anything like the size of the ID of this valve, because there's a risk
Okay,
you
so
would
valve pause.
tear.
Yeah, we use
tear the
tough
leaflet.
we use similar like 18.
Confirm.
Yeah.
I think
Well,
that
we just use a peripheral 10 millimeter balloon that seems adequate to get across.
The Sapien
very
3 crosses
dramatically.
pretty well.
Okay, so pause, pacer, wire, prosthesis. We're happy.
Very good.
ACT is good.
So are you feeling any stress,
Maybe
David?
some tension if,
You have picture-in-picture hemodynamics as well, please. Have both.
Did you,
No, I enjoy crossing live, John. It's my new thing.
I don't know if, I was pretty impressed by the calcium in that aorta.
Cranial 15, please.
So do you have experience with the pre-mounted, have you
John, the
tried
access
it,
was very,
The
very
Ultra?
challenging.
Yes.
Up one meg.
So I think people are going to
Get ready
like
to do
that.
this.
You know, I
Dale.
think some people are so used to this system that they're not going
Ready,
to
Dale?
care very much. Like, we don't find it a big burden to align the valve, but it is one less step. And,
Up one meg.
Not having to pull a flex cath back is, I think, a potential advantage. People won't make that mistake of forgetting to do that.
But and you're not compromising on profile.
No, the profile's actually better.
Straight AP.
Yeah. And the 20.
I always like David's commands.
It's gonna give you
you
some
know,
tension.
Down a
very-
meg, please. LAO 30, please.
See?
David has a nautical heritage, so he's used to being captain of things.
Yeah, yeah, I could tell.
you need more of it.
So was Eberhard, right?
Abdullah, make it so. Tension on the wire. Yeah.
Make it so.
He was captain of the ship, right? Eberhard?
Yep.
Okay, implant angle, please.
See?
Ron, we're going to get ready here in just a moment. Pressure looks good.
So we have a little routine. We stop above the valve. We go to the implant angle, implant mag. We make sure the pacer looks right, the pigtail looks right. The pressure is good, the pump is ready.
And
We check with everybody. It's a good
I think
policy.
it's a very important step here, and I totally agree with you, John. Before you get in, just get everybody organized.
Yeah.
And
I
get
see a lot of people, they put
You're
the
gonna
valve
go up.
straight across.
then-
and then
We're
they
not gonna
think
do an
they-
injection.
Yeah,
There's no
yeah.
point
I think
there.
that's a very, very good point.
So in valve, implant angle has a little bit different than in the native when you're trying to align the three. So can
Well,
maybe
we
David-
usually align the two
Hey, we're-
posts either side of the left
right.
main
So
like
can you,
this.
maybe he can discuss that.
Can we take this off?
Do you want to discuss the
Can you-
angle you've chosen, David?
He's too busy. That's fine.
Go ahead, John. I'm just going to focus here because I think we've
Okay.
got a hard out for the timing.
We'll
and I still
just
wanna do the
we'll just
fracture.
go ahead talking. You just go ahead and do your thing.
But I think
Now,
this step is an important one, John. and I think it's
he's
worth
act-
being.
I think he's
okay,
actually-
see how it jumped a little bit?
Yeah.
And now they concentrated because now it's the time to
Yeah.
pay attention.
Okay. Now, I think I'm not sure if he's bowing the leaflets down. He may not actually be across. Oh, there he is. He's probably across
Yeah,
now.
he is, right
there. Okay. Now, now you don't want to go too low because, you can get in a situation where you have the Sapien stuck in the LV
Yeah, I had one.
underneath the valve ring.
I did have one.
And the only thing you can really do is move the flex cath down to the valve so you have a smoother
Yeah.
So
pullback.
what's your target here?
Well, I would typically put the top of the Sapien 1 to 3 millimeters above the top of the posts. And because the valve is going to shorten up. So I wouldn't worry so much about the bottom, but worry about the top.
Up one meg.
Now this is kind of a short valve, so I would put the,
Perfect.
just about there, 1 to 3 millimeters above the top of the posts. And then I would go up very, very slowly.
Yeah.
You see how he's
think
nice
that's
and
pretty nice.
coaxial? You get
Looks good.
coaxial, the best way to get coaxial is to rotate the whole
Hemodynamics are
catheter.
stable. Are you guys happy with that positioning?
Yes.
Excellent. You take the whole catheter and you rotate it counterclockwise, and that will bring it up.
Yeah.
Not the way you teach you. Flexing the catheter has nothing to do with this. It's rotating the catheter.
Everyone quiet. Pacemaker ready. You're going to go up very slowly. And pacemaker on. Start going up slowly.
Going up.
Keep going. Keep going. Keep going. Keep going. Keep going. Keep going. All the way up.
All the way. 1,000, 2,000, 3,000, and down.
And pacemaker off, please, Ron.
So that's a little higher than the last case lower than the last case you saw. It could have been a little bit higher to optimize the leaflet position.
It looks pretty good.
But it looks pretty good.
Yeah.
But there is a bit of an indentation. It's not too impressive, though. I thought it might be a bit more impressive.
So that's, yeah. So for those who do the cracking, a priori, this is probably shows why not.
Yeah.
You can try
But
to
I think if you look, you can see that he's actually stretched the
take this out.
paramount valve.
Yeah.
You can see that radiopeg
So get the picture.
plastic impregnated ring
That's fine.
was wavy and now it's straighter. So
Yeah,
in fact,
but leave the wire. Leave the wire.
he has stretched it bigger than.
depending the
size.
gradient, you may
Down
not
a mag,
need to do
please.
it, yes.
Down a
Which
mag.
gradient would you accept before cracking?
Well, I don't know the right answer, but people lately have been talking about whether you should routinely crack if the gradient's over 20, say.
Yeah,
And that would be a reasonable kind of threshold. Now, of course, it depends on what your cardiac output is. And I think it should also depend on the appearance of the
Do we wanna
valve. Does
do
it
the
look
gradient, or
grossly
do we wanna-
underexpanded?
Particularly in this case, it looks okay.
So,
Yeah, that's why
John,
I think it's.
that's what
Everhart,
I'm saying.
This might be okay, yeah.
we were planning on going ahead with cracking now, but do you want any additional information?
Pressure.
Focus on this.
Pressure gradient.
Show the deployment.
People are interested in whether there's a gradient across the valve.
John is
some-
not, but we are.
You know, we're doing a little study where,
Okay, let's go ahead then. We'll do the gradient.
where we'll do routine.
Yeah, that's a good thing. I
So
think
do the gradient, and then if it is pretty good, then there's no need to. Well, nobody has talked about the complication of cracking. I mean, it cannot be like zero. So what's the complications?
Well, I know that there have been some aortic hematomas seen on echo, but I'm not aware of any frank ruptures. I know I've heard of core valve leaflet tears because if people put the balloon too high, they get up to the narrower portion of the core valve with the commissures and can tear the leaflets. So that's a
Let's get this right
concern.
Turn that
There's
off.
a slightly higher rate of pacemakers, because of course you're expanding this in the region.
So why would it
of
be
AV node.
safer than, I mean, still the annular rupture is about 1 to 2%, correct?
Well,
And
no.
in native standard.
Well, no, even there it's, so in the partner
So
study,
look at the
intermediate trial, it was-
look at the gradient here.
There's no gradient.
No gradient, so, yeah, that's the,
Well, that was my
the
point.
suggestion.
You can
Can we zero both, please? Can we zero both?
Why,
yeah, that would be important.
Zero both?
Zero both is good.
That's looking good, it's looking good. So what
But
is
it looks good.
Yeah, what's the compelling, at this point, reason?
Well, there is no compelling reason. But I think there is a question, but would the durability be better? Would thrombosis risk be less? I think somebody will be doing a study. There will be people that are, there are people planning a routine post-dilatation for low gradients. But I think clinically, yeah, why argue with the perfect, why argue with a perfect result?
And the surgeons say, don't touch the leaflets because that's part of the durability. Imagine now you're stretching it with a balloon.
So David, people are thinking you should leave this alone.
We're pleading to leave it alone.
They think
Look
it's
at
perfect.
that. I mean, the result is good.
Yeah, look
It
at
is
this.
perfect.
I'll defer to this panel, but
Even Dr. Grube thinks the result is great. You can hope for no more.
show our faces, please.
Go home, that's it.
Dr. Bookbinder says go home.
Sailing.
Let's bring the true balloon up so we can at least show them.
Where's the aortic pressure coming from?
So after you do
So I think this is interesting.
There's
you need to think this through.
there's no way I'm going to argue with such an illustrious group, but why don't we just show?
That would be great if you did that.
Yeah. So I know there's a delay, but focus here. What we've been doing in Vancouver, and I know different people are doing this at different centers, is we use a large inflator and a small one through a three-way attached to our true balloon. Abdullah, maybe you can take us through what we would normally do here if we were going to proceed with cracking.
Sounds good. So usually the problem is that you don't have enough
Dale, can you go
volume
across my
in this deflator with a manometer. So what people usually do, they have a big syringe here. They inject first. They have it locked like this. They inject through the syringe here to fill up the balloon. And once it becomes really difficult to raise the atmospheres, they flick it and then they use the locked end deflator to raise the pressure of you know, say 18 or 20 atmospheres, human power cannot do. So, but the problem with this strategy is that it involves two operators, and they have to communicate, and there's some maybe delays. So this could potentially be a very prolonged inflation. So what we've done here, we hooked up a large manometer which has 38 cc's, which should be sufficient for one inflation just using this. The problem with using only this, that you cannot know what the pressure you're reaching, which is very important. So we use the other port here, connect the locked deflator, so we know what the pressure is as we are going with the bigger deflator. So it's one operator can look at the pressure reading here and use only one deflator, have it open, go all the way as much as possible, and when it cannot go anymore, lock it and use clocking to raise the
Abdullah, let's actually show them that.
Okay.
Go ahead. So turn it. We'll pretend that this is inside the valve here.
Okay. So I usually have it open.
Yeah, but you're going to fill it the same way.
No, this is locked.
Yeah.
So have this one's locked.
But this is, just so we're clear for the audience, pan out a little bit, this is how we're going to be reading the pressure. And as you know, we need up 18, 20, 22 sometimes
depending
to
on
crack these valves. And so we've got this open so that one of us can read the pressure so we know actually what's happening. And then Abdullah is going to go up with the large deflator.
I just want to highlight the point, the way that the three-way stop is being turned away from both, so you can have pressure on one and continue to inject through the other one. So the way this works, that we have it open, then we go up as much as possible, and you can see the pressure here. I mean, I'm only generating 8 atmospheres here with my strong arm. At this point, I lock it, and then I can continue cracking it, and then I'll show you the pressure there. So as I'm cracking, you can see the pressure is raising.
And I would encourage anyone who's doing this and is going to be using this type of non-compliant balloon, this is like a rock.
And this is at 20 atmospheres.
This is 20 atmospheres, which is what we thought we would need here. And you can see it's got a little leak there already. But this is like a little piece of concrete. Can we raise the eye up so we can get an echo there? And then just come back out so we can see the room. So John, that's our setup, as you know.
That's great. So you really need a true balloon, or a very non-compliant balloon here, I think. And the concept, I think, is to have a balloon that's just about the outer diameter of the surgical valve, not too big. Because you don't want to explode it, you just want to crack it.
Patient wants to get up, John.
We use the true, but we've seen these little micro leaks, and the next one is the Atlas.
The Atlas,
and it is shorter, and it does the job as well.
Well, it's available in a smaller ranges of sizes. I think the biggest Atlas you can get is 20, maybe.
20,
yeah. So here we are. Usually we have transthoracic available on the echo. We don't routinely use it, to be honest, for valve and valve because they never have leaks, right?
Yeah.
So our routine lately has been to do these without
very nice.
Without
very well
contrast.
done, David and team there.
Yeah.
Very nice.
Any color?
Well, that's great, guys. We're just going to close now. But
so
you basically saw the thought process, how we would do our intentional valve modification with cracking. The team did a great job to get everything ready here, and enjoy your time in Korea.
So I know it's late there, and we'll see you tomorrow. Good night. Thank you very much.
Okay.
Well,
thanks, guys.
I think we'll end it there.
Yes.
We're out now.
Thank you
Don,
very much.
confirm that we're out.
Good night.